and we are delighted to welcome you for the first time to our council this morning. So please join me in welcoming Kimberly and Judi.
Okay, so you already have my short bio, and I kind of introduced myself again. My name is Kimberly Russell. I'm a physician assistant. I worked here at Long Beach Memorial Miller Children's Pediatric and Family HIV Center for about 2.5 years until just recently, where I left in the beginning of August to start working in pharmaceuticals as an HIV market specialist. What I want to talk to you guys about today is HIV and AIDS mostly, as that is my background. And Judy's going to stand up and give you all a little bit of information I'm sure you know very well about domestic violence, but make some of the linkages between the two. Obviously, since you're having this topic, you understand there is a connection between the two. And I'm going to spend some time just going over basic definitions, a lot of which you may know already, a lot of information you may already have. But if you would please just take note, maybe you can talk to some of your patients about this, some of the people you see every day, so that you're educating them, because I think that's really the take-home message today. So again, the purpose is just to identify the connections between HIV and domestic violence and to clarify definitions, risk factors, symptoms, statistics, and then at the end also, very important, encourage prevention and testing. So what is the connection between HIV and domestic violence? When I was given the opportunity to put this together, I've learned so much just thinking about it, because I think I got so stuck thinking about HIV, and although I was seeing a lot of signs of domestic violence when I was treating patients, I didn't really put together kind of how common the risk factors and warning signs are for both. So this slide kind of puts together that information. Obviously, both are going to prey against the vulnerable, both create a victim. They're unavoidable. They're both very stigmatized in our community, misunderstood, ignored, and unfortunately, both very well could be lethal. So when I was speaking with Judi about this, when we were getting ready to do this together, we came at it obviously from different backgrounds, and what we were trying to figure out is whether it's people with HIV that are more likely to be victims of abuse or become abusers, or if it's the other way around, and you see victims of abuse and abusers more likely to acquire HIV. And I think it goes both ways. And as you see here, I just made some notes about both situations. You're going to have anger and rage regarding a diagnosis of HIV, which may lend itself to someone becoming abusive. People feeling a sense of depression or a loss of self-worth. When you're talking about victims of abuse or abusers, again, that loss of self-worth or loss of bargaining power to be able to stand up for themselves and say no in a situation where they may be putting themselves at risk for HIV. So I'm not sure about what you all are seeing, but I put together some anecdotes of what I was seeing when I was practicing and taking care of people with HIV. What I did find is that, and this is per a web search, women who have violent and domineering partners have a 50% increase of acquiring HIV. Many women, as you know, are very afraid to even discuss the use of condoms with their partners if they have a violent or promiscuous history, because just bringing up the topic is going to cause potentially a violent reaction. I'm not sure how much you all know about living on the down low, or the living a secret life that we've been hearing so much about in pretty much all cultures, primarily African American and Hispanic men is what we were seeing a lot of in my practice, where you would have men that had wives or girlfriends and families, but they were unfortunately having the secret life where maybe they had homosexual tendencies or would never identify as homosexual or gay because it was stigmatized and unaccepted in their communities, but they would go and have secret lives that no one was aware of, acquire HIV many of the times because they weren't using protection, and then come home and infect their wives or girlfriends. And we saw so much of that where women, because the clinic is mostly family-centered, and about 90% of the adult program was women. And the women that we saw most often found out their diagnosis when they went in for their pregnancy test. for their screening when they were pregnant. Luckily, they were given an HIV test at the time because we can prevent the child from getting HIV, but that was at the time that they found out. They had no idea they were even at risk because they were in a monogamous relationship. They were, happily married or in a very happy, time in their life, pregnant, going in for prenatal care, and no idea that they were at risk or needed to get tested. So unfortunately, we're seeing that they were, victimized and became subject to the risky behavior of their partner. And I guess we can kind of look at that as a type of abuse, if you think about it. One of the statistics that Judi pulled up was that 42% of murdered women are killed by their intimate partners. And that doesn't even incorporate the additional percentage if you were to look at HIV as a type of murder that these partners are giving to their partners. So what I'm hoping today to give you as the message is that we need to educate ourselves about each epidemic. Obviously, you all have become very educated and well-versed in domestic violence. I'd like to educate you about HIV. Keep it in mind when you're talking with people. Screen your patients, the people that you come in contact with every day, because they are so connected. And never make assumptions about risk factors. Don't think that because you're looking at someone, you know that they may or may not be at risk for HIV, because you don't know. Any one of us could be at risk. And hopefully we're going to destigmatize this disease, as well as I know you're making efforts to destigmatize domestic violence and have people talk about it more openly. And we can do that through education and acceptance. So again, please forgive me if I am speaking at a level that's below you as far as your HIV knowledge, but I'm going to use some basic slides that I've used in the community to talk to college-age students to help them understand the basics of HIV so that they can make better decisions. So what I always start out with is just the difference in the definition. Human immunodeficiency virus, which is HIV defined, and HIV affects your immune system. If you're HIV infected, you will have a drop in your immune function, and you will have less of an ability to fight off infection. It is a virus that causes AIDS, and AIDS, defined as acquired immunodeficiency syndrome, is characterized by opportunistic infections, that is, infections that take the opportunity that you have a low immune function, like PCP, which is the pneumonia that you've heard about perhaps, or wasting. There's a list of about 20 opportunistic infections that would define you at that point as having an AIDS diagnosis. You can also be defined to have AIDS if your T cell count, which is one of your white blood cells that fights infection, drops below 200. It's just an arbitrary number at which you basically have a lowered immune system to the point that you will start acquiring opportunistic infections. And if you, just to give you a sense, healthy people, non-HIV infected people have about 1,000 T cells. So again, basic slide, HIV is carried in 4 body fluids. I always go through this just because there are so many myths surrounding how you can get HIV. Blood, semen, vaginal fluids, and breast milk. Be aware that there are myths. I mean, a lot of people are not aware that you cannot get HIV through saliva, that you can't get it through sweat or tears. So these are questions that if you start talking about HIV, you might find people have questions about it. Modes of transmission, as we all may very well know. One of the interesting points, and one of the reasons I loved my job so much, is the mother-to-child transmission rates that have drastically declined. Pregnant women without treatment, about 1 in 4 will transmit HIV to their child. Pregnant women with treatment, so obviously the point is that they know they're positive, that they're getting into prenatal care early and they're getting a test offered to them, which is law in California, is actually less than 1% chance that the baby will become infected with HIV. Symptoms and treatment, just briefly, if you are HIV infected, initially about 1 to 2 months after exposure, you may have very mild flu-like symptoms. Not everyone has them, but you may develop a flu-like illness. If you know you've had risky behavior about 2 months ago, then that should be alarming. Otherwise, you may just write it off and let it pass, because it very well will pass, just like any cold or flu that we need to work through. But the key is don't be worried about every flu-like illness you get. Just think about what your risky, your risk behavior has been. Treatment, again, there's 26 medications right now on the market for HIV. They're all very effective, very potent, very difficult. I will add, it's not no big deal anymore just because there's medications available. Very difficult to adhere to, and the side effects are very difficult to handle. But they've made huge advances. There is assistance available for people who have no insurance, AIDS Drug Assistance Program. There are combination doses. They're trying to make efforts. There's been a lot of effort made to make it easier on the patients, but hopefully we can prevent as opposed to treat the disease. I just wanted to talk a little bit about the connection. I don't want to be too much on a tangent here, but the point in this is that for some reason sexually transmitted diseases are discussed more openly. They're less of a stigma somehow surrounding chlamydia, gonorrhea, syphilis, and it may be something that you hear when you're talking to your patients because they'll openly talk about it, whereas the HIV is completely off limits. They won't talk about it. They won't get tested, perhaps. But when they're talking about STDs, be aware that this is a huge problem. If someone's talking about being treated for chlamydia, STDs can raise the risk for HIV infection 3 to 5 times. So anytime that any one of your patients is willing to go get a test or goes to their doctor to get a test for any sexually transmitted infection, make sure they know to include HIV, okay? And also open up the communication there. What's happening if obviously people you're seeing are already victims or may already be at risk for domestic violence, so you're gonna be talking about how you can help them with communication in their relationships. But a lot of times we saw, when I was doing primary care about 3 years ago, 3.5 years ago, we would see people coming in with positive chlamydia tests and they didn't want anything other than the antibiotic. They didn't want to know how to talk to their partner. They didn't want to know what it really meant as far as the fidelity issues. They didn't want to know anything. They didn't want to talk about it. They just want to take the medicine and go home and have their life the way it was before. So what's happening as far as communication? Obviously there's a lot of fear and insecurity there. Briefly, I just wanted to review statistics, and these are statistics from 2004. In 2004, they were saying that since 2002, the number of women living with HIV has increased in every region of the world. In many parts of the world, marriage and long-term monogamous relationships do not protect women from HIV. There's some statistics here about Asia and sub-Saharan Africa. One that I found particularly interesting is that in Zambia, only 11% of women believed that they had the right to ask their husbands to use a condom, even if he had proven himself to be unfaithful or was HIV positive. So that's what we're dealing with in Africa. And what I would do when I would talk to college students about this was say, that's not the case here. You have every right to say no. You have every right to ask. You have this. There shouldn't be such a feeling that you don't have a say here. And I know that's an ideal perfect world, but that's what I think a lot of young people need to hear. This is just a global summary talking about HIV and AIDS. The total number of people living with HIV in 2004 is just under 40 million. People newly infected, so again, this is world statistics, just under 5 million. So we've made advances. There's been fewer infections, but again, unfortunately, in 2004, we saw a slight upswing. We saw new infections out of nowhere. And for especially here in the United States, where we pride ourselves in being so educated, we still were seeing many people becoming newly infected. AIDS deaths in 2004, and that has been on the decline because of these medications that are keeping people alive longer, is around 3 million. So just to recap, kind of put it in perspective, 14,000 new infections in the world a day in 2004. 95% of those are in low and middle income countries. So almost 2,000 are in children under 15 years of age, about 12,000 are in persons aged 15 to 49, of which 50% are women. And that has been a huge problem. You know, in the day when we, you know, kind of looked at HIV as a gay disease, or back in the day when we didn't think it was going to affect any other demographic, you know, some people felt safe. And now we're talking about HIV in women as 50% of the people with new infections are women. Okay, and I know you see a huge number of your clients are women. Just so a worldview, if you look at where you're seeing HIV in adults and children, obviously sub-Saharan Africa, 25 million. It's just incredible. North America, you know, we're on the map. We're definitely there with 1 million. And then estimated number of adults and children newly infected with HIV in 2004, North America, 44,000. But look at the rest of the world. I mean, you're still having 3 million new infections in sub-Saharan Africa in 1 year. This is an old slide, but I think it's very important to look at the racial trends. You look here, you see that white, non-Hispanic is on the decline, and our minority groups, Black and Hispanic, are on their way up. And actually, if you look here, this ends at 2002, but for the last 3 years, Hispanic has been making more of a rising trend. These were some of Judi's statistics, just talking about domestic violence. You may be very familiar with these. Every 9 minutes in this country, someone is assaulted. 4 million women are physically abused by their husband or live-in partners each year. And it just puts, you know, into perspective that these are two very silent epidemics. Some more statistics here. I want to talk about prevention and testing. I'll talk about some of the methods of testing. There is, whenever anyone goes in to get a test for HIV, what the test is looking for is the antibody. It's looking for your body's response to HIV virus, to being exposed to HIV. So it's not looking for the antigen, it's not looking for the virus. If you get a standard HIV test, it's looking for your body's reaction or response to the exposure, so your body's development of an antibody. And the reason I mention that and go into so much detail is because people will go in maybe the week after they've been, you know, risky and they've had risky behavior. And that's not going to tell you definitively whether or not you have acquired HIV or exposed yourself to HIV, because it takes our bodies at least 3 weeks and up to 6 months to develop the antibody. Okay, so we want to make sure that if you're seeing people who are admitting to risky behavior or have concern about some behavior that they've had, that you explain to them they're welcome to go get a test tomorrow, but they need to get a subsequent test to confirm it. And they'll tell you that. Hopefully in a good center, they'll tell you, that information. There are more definitive tests. In pregnancy, we don't rely on an antibody test. If we have a pregnant woman who we're concerned about, we would see this a lot actually. Maybe she had an antibody test and it came back positive, or even if it was negative. A lot of times if she has high-risk behavior, and this happened a lot when you saw women without prenatal care showing up to the labor and delivery room just ready to go, the rapid test is an antibody test, but what Dr. Vivikas would do, and she was, I'm not sure how many of you know her name, but she's the expert, is do HIV DNA testing. And so that is looking for the virus. And so that is going to be definitive so that you can get that person on treatment immediately, especially in pregnancy. You want to make sure that you don't hesitate. There is an oral test, and there is a rapid test where you can get results much more quickly, and this is a big problem. People aren't going back for their results. So they build up the courage to go get a test, but they have to wait 2 weeks for the results, and they fall off. They don't go back, they don't find out the result, and so yes, they had a test, they feel good, check that off the list, I had my test. They never found out whether they were positive or negative. And a lot of times it's difficult. If it was an anonymous test, there's no way to track that person. So, Early detection is critical, and what I advise is testing every 6 months for your high-risk people. This is ideal situation, I understand that. I made this slide and it's kind of laughable. I don't think that it's true to life, and especially in the setting of domestic violence. I don't know that you're having a conversation necessarily before you have sex with a new partner that's abusive, or you know, in a situation where you don't have a say about having sex, where you can ask them what their status is. Obviously that's ideal. Limiting alcohol and drug use during sex. There's a much higher rate of having risky behavior where you might not use protection, or you might engage in activities that would put you at higher risk if you are drinking or intoxicated. I have a list here, and we can go back here if any of you are interested in the end for different places that you can find information or give to your clients about testing, and I'll come back here at the end if you're interested. Just want to, this is my final slide, and I want to pass the microphone over to Judi, but just please hear what I've said. I know I kind of went through it quickly, and I'm happy to talk to you separately if you have other questions, if I didn't get into anything you have questions about. Again, it was somewhat basic information about HIV, but I'm hoping you'll pass it along, and I'm not sure the education level of the people you're talking with, but hopefully hammering home that this is something that you all need to be talking about. You need to be aware that this is happening, that this is a silent epidemic, as is domestic violence, and when you're seeing your patients or your clients, this is very real in their lives, and they are probably not that aware of it. Okay? Educate yourself, which is hopefully what I helped to do a little bit today. Screen everyone that you see for risk factors for HIV when you're talking to them about domestic violence and other risk factors in their life. Never make assumptions. I have a zillion stories I could talk to you about. So many patients that I've seen where it was not thought that they would ever be somebody with HIV, and so they were never offered a test, and now they're living with a disease that could have been managed so much easier if they knew earlier, or if they could have done something to prevent it because someone talked to them about it. And we need to destigmatize. We need to stop thinking of this as such a stigmatized disease. Educate your clients and build an environment where you accept them no matter what.
Thank you, Kim. Wow, what a great job. I feel like I'm going to be preaching to the choir here, because a lot of you are coming from domestic violence backgrounds and shelters. And, so forgive me if I am redundant. This was a true privilege for me to investigate a little more of how HIV does affect women and men, especially women in the domestic violence community. I do workshops throughout California, and this brought a whole new light to shame, to going deeper underground for women, especially for women, and for the silence. It's even more silencing. These are the different types of abuse, as you're well aware of. The sexual abuse, as Kim talked about, what I saw as I went and investigated is that women who are that have HIV, or that women that are involved with partners that are promiscuous, like Kim has said, and that are violent, these women don't have a say. They can't say, even though most of the time in violent relationships they don't have a say. It's usually if they do say no, it is the time when violence will escalate to a sharp degree. But if they are in fear of having a partner that has a sexually transmitted disease, the risk of even talking and broaching the subject of saying, could we talk about using a condom, will also escalate, because of course we all know that domestic violence is it is about anger, but it is more about power and control. Now, of course, this is the definition of domestic violence. This is the most exhaustive one that I could find that I use a lot. the use of physical force, restraint, or threats to force to compel one to do something against one's will or to do bodily harm to self, cohabitant, family, or mother or father of one's child. It includes, but is not limited to, hitting, biting, threats, or use of weapons, sexual assault, pushing, slapping, choking, on and on and on it goes, physical murder. Psychological intimidation or control may be maintained through such means as stalking, harassments, threats against children, and violence against pets. See, these are some of the signs and symptoms of individuals, which I know that you know. But as I was investigating the HIV population, what was brought to my attention is that if a woman is, especially in the homosexual community, if they are in a relationship with someone, if they have HIV, if they are in an abusive relationship, they will go more underground rather than calling and reporting it. Why do you think that is? Anybody even take a guess? Well, I just found it fascinating that number one, they are so protective of their partner that if they have HIV and it has not been reported, if they're abused and the police come and they go to the hospital or they are taken into a shelter, guess what happens? They have to report their partner's identity. And they are so afraid. It goes back to all the socioeconomical reasons of why abused women and men stay in abusive relationships. It's fear of losing a partner. But in their case, it's fear of losing a whole community. And it's almost a double shame. It's a double burden for them because they have a community that has accepted them. But when they go out into a community and they know their sexual identity has been exposed and they have HIV, it's a double burden for them. So just like Kim had said, they tend to go underground. They get more depressed. Suicide is on the rise in this community. So anyway, this is some of the obvious signs and symptoms. Denial and minimizing, of course, is huge. It's huge in this community as well. Women and men, but mainly I was thinking of and researching on women. Women with childhood abuse are much more likely to enter into abusive relationships. Of course, I'm sure that most of you know that. But and they're more likely not to have a voice of how to set boundaries, of how to say no. They are in this, and the minimization is, well, I've been here before. This is what I've lived with all my life. So this must be me. It's about me. So self-hatred comes in, self-rejection comes in, and when HIV is involved, then it's almost like, oh, I deserve this, especially if they've acquired HIV prior to entering into a new relationship with someone. And so it's very shaming, and it's very depleting, and it depletes them of their power to enable themselves to, unless they've got good community and good undergirding of counseling, to get out there and make decisions for themselves. So you have a double burden of women who can't say no, and women who have a disease that's stigmatized and they're ostracized from the community. So isolation is huge, and isolation becomes even more prevalent. The cycles of violence, we all know the cycles of violence, but this is, again, it's perpetrated even deeper into the HIV community. The first phase, of course, being they sense that they're beginning to, their partner is beginning to escalate. They're sensing more of a control. They're sensing more of verbal abuse or emotional abuse. Maybe the dog is getting hit. So they're starting to tiptoe, or they're starting to pull away. And then eventually phase 2 comes, which is the actual act of physical violence. When that happens, why most women stay and men stay in relationships, I'm sure as all of you know very well, most of you, is that they wait for phase 3. It's the honeymoon stage. It's the stage of why they began the relationship in the first place. It's where the flowers come, or the promises come, I'll never do it again. It's where the romance begins again. It's the security happens. It's a place of feeling safe, once again, even if it's for a moment, it's for a moment. And it takes away from the stress of having to have relived phase 1 and phase 2. It's a relief. And it's a place where they think, well, maybe this time. But usually the perpetrator they relive and rewrite reality. If they are not truly what I call repentant, they'll rewrite reality and say, well, you know what, even if I did hit you, if you didn't have AIDS, if you weren't infected with HIV, I could handle this relationship a lot better. It goes to the if-onlys, and it's always usually it's the victim's fault, and it goes back. But especially with HIV, there's such a core of shame with them, such a shame that says I am, and it's a toxic shame. I'm the mistake. I made a mistake, yeah, but I am the mistake. And I haven't really dealt with women that have had HIV, but I've dealt with women that have had STDs. And it does perpetrate and gives a hand and leans a hand to them staying in a relationship because they have a belief system that says, I won't be able to find anybody to love me ever again. It's very sad. This is my PowerPoint that I use when I do workshops, and this is if the abuse is still at phase 1. What we do is we give classes on boundary setting to women who come out of abusive relationships. If it's in phase 1, if it's verbal abuse, if it's emotional abuse, if it's even property damage, if it hasn't gone to them being physically threatened or violated, then many times there is help. And just teaching them, showing them who they are, giving them power, and encouraging them to know their identity and who they are. Of course, if the abuse is at stage 2 and the physical violence is prevalent, I do this too as I teach lay counselors, let your supervisor know, and then offer a plan of safety. It's hard to offer a plan of safety when they're underground. This is a challenge. I think it's a new challenge. It really woke me up to the women out there and men who are hiding because of this issue. This is the safety plan. It's minimal. It's pretty condensed. But if you're interested in it, I have a whole safety plan that we use. And if you can get to them and you can extend your hand to them as advisors, as professionals, as people in the medical community, know that this truly is the key. And I'm sure a lot of you know this, but when you are discussing leaving with a woman who has been abused, leaving is the most dangerous time for anybody to leave a relationship. It is the most dangerous time. It's the time when murders happen. It's the time when physical violence. When I left my relationship, it was the worst beating I had ever received, and I received brutal beatings. But when I chose to leave, that was the worst time for me, and it's because of the loss of power and control. This is my take-home message. The best vaccine for HIV and domestic violence is empowerment. It's the best way to reverse this epidemic that I know of. And until we can change the apathy into strength, we'll be fighting a losing battle. So I thank you so much for your time and your attention, and feel free to ask us any questions, and hope that we stimulated some good, heartfelt conversation with yourself, and maybe hopefully brought an awareness, as it did for both Kim and myself, to a new level of women and men who've gone underground. Thank you.
Any questions?
This is just one of the terms that you use, the DL. What did you say that was?
Oh,
down low?
It's the lingo that they use.
Okay.
Right. Living on the down low was the term that they gave, and it's actually not that new, but they've been talking more and more about it. I'm sure some of you are very familiar with it, but basically it's living the secret life. So they had an Oprah special on it. It's basically a scenario where you have one life, you have a family, maybe you have kids, you have maybe you just have a girlfriend, you're living with a girlfriend, or you're in a relationship, and this is one life. And then you have the need to go have another life, maybe because you have tendencies towards homosexuality, but you would never identify as gay because it would never be accepted in your culture. Or you know, it could be, I guess when they talk about down low, they're talking about having relationships with another person of the same sex and keeping that as your secret life. And then not talking about it and going home. And that's the problem with that, obviously, is that you have promiscuous behavior that's going on most often not protected, and you're going home and infecting, you know, the family.
So when you say DL, is that usually pertaining to the sexual activity or?
Just down low. I think it just means like secret. Secret. Anyone want to add to that in your experience? What that has meant in your clinics?
Well, one of the things that I sometimes see in working with gay clients with AIDS or their partners, and I don't know if you've seen this, is that sometimes, sort of in the control that you were talking about, that sometimes medications are withheld or threatened to be withheld, that some of the fear of exposure is used as a way to control, that the disease itself is used as a way either to threaten the victim, as you talked about, you know, without use of condoms, whatever, or to control the victim who might be the one with AIDS in terms of lack of medical support.
There are situations where the partner becomes the caretaker, and so they're in that position of power to withhold the medication. And that's a great point.
Well, I think it can even be at the point prior to being a caretaker. You hide the medication, somebody could be totally healthy and functioning in the world. And you don't even have to be at that point of disability.
Hopefully in that situation they're able to communicate with someone to get more medicine.
Are there other questions? Then please join me in thanking again Kimberly and Judi.